that's an ACE, but the bottom line is we don't need to do that. So we're going to pay attention to that. Now, what about this grade thing? So when you read, a lot of people just keep saying, you know, it's the evidence that matters. Well, it's not just the evidence that matters when you implement. Evidence is one key thing. And of course, you have 2 large RCTs, it's likely you're going to get the result you're expecting. But if you don't have that, what else? Could you have very little evidence and still implement? Well, this next piece is the balance between desirable and undesirable is really important. So if the desirable thing you're going after is not having a heart attack or stroke in a high-risk person, the undesirable is I might have a cough or muscle aches until we change the medicine. A lot of people will say, that's so strong, I'll go with a little less certainty. Values and preferences, of course, we have to listen to in the patients. They come in with everything in the world in their mind, and you have to listen to it and deal with it. We don't do that here, but you do. You have to when you implement. And costs. So if indeed a new PCSK9 comes out at $14,000 a person, and you do all of these other things, and and they are equal, the quality, the benefits, etc. And it costs $100, then you're going to go with the other one. So it really does help you adjust for where does cost fit in. Okay, so what about modeling and stroke? Well, so there's this big program called Archimedes, and in the program, for this example, they took all of the papers, all the randomized controlled papers on diabetes and cardiovascular disease treatment. And then they press the button, they ask a question and press the button, and it does an instant meta-analysis for you. So this was done. The question was, what if we control blood sugar, and what if we control, or what if we add a bundle of aspirin, lisinopril, and lovastatin? And what you see in the blue on the left-hand side here in MIs is nothing. And what you see in the, I don't know what color is this, magenta? What is it?
Yeah, that's good. Yeah, magenta, yeah.
Okay, that magenta is, you can see a little tiny bit on top. That's really kind of interesting because the Accord study actually found a 10% drop in acute MIs, but a 20% increase in all-cause mortality, so they can't go after the 10% when you're hurting the thing you're going after. But the model was really correct. It picked that up. And the same with strokes. 71% was predicted. So what happened? Well, it turns out we presented this to the board at Kaiser, and we did sort of what grade would say to do in our heads and said, you know, gee, we can do it cheaply. The statins became generic by then. We know that we can implement across a large group if we do a bundled thing, and we know that the benefits far outweigh the risks. So we're just going to go do it. So we did in all of California. We started with 170,000 people, 2/3 of which were diabetic, 1/3 had CVD, and 100,000 over the next 2 years we didn't get on. But 47,000 got started, and they did it with low adherence, and 21,000 got started and did it with high adherence. And then we looked at the 3 years, what did we see? What we saw was in the low adherence, a 15 per 1,000 drop, which was 60% of the base, and a 26 per 1,000 drop, which was 80%. So actually the predictor was really right on. Again, making you feel comfortable both in the predictive tool and in the outcome. So we were really pleased with the fact that we got something that we thought was pretty decent. Well, but we could, you know, there it was diabetes, CVD. What if we wanted to do more? So what about treating hypertension? We noticed there was all those people out there. And so we looked at hypertension over 55, and what we looked at was systolic over 140 at age over 55, looking at ACE or an ACE thiazide or a statin added to the bundle. And Ron Scott gave me this. This is So you can make more sense now. We've gone farther with statins. And so if it's over 10%, you start the statin. So that would fit with the criteria we had. If you're 7.5 to 10, consider a statin. 5 to 7.5 is considered discussing statin. And the nice, important thing here, though, is the patients are flagged when they need it, and there is metrics that are followed up to be sure that things are started. That will be important. So what did we find in the model, though? This was before we had any results. And what you see on the left-hand side was if we used, is the MACE, the traditional MACE, death, heart attack, stroke, or death from. And you can see with using just an ACE, you got a nice drop. What you see, though, is if the thiazide were added, you doubled the benefit. But look at this. This is simvastatin 40 alone was more powerful than the combination of blood pressure medication. And you're going to see a close combination when you see the Barbershop and stuff, because they look at this. And that's pretty darn close. Remember, predictions have a little fuzz to them. But the bottom line is you don't forget to take care of the plaque when you're treating hypertension, because if you do it, then you get to that fourth, a quadrupling of benefit. And you can start all three of these at once because their side effects are different. Yes?
Could you just elaborate to the group who doesn't know why plaque is relevant here?
Oh, okay.
You said you've got to take care of the plaque,
Yeah,
so
sure.
you've got to explain what.
Yeah, with cholesterol, as you know, it can penetrate the wall of the artery and start to be accumulated. And when enough accumulates, it obstructs the artery and the edges crack or break or something happens to have an infarct happen. So that means, and so that's fundamental. Without starting with that, then your chances of having a heart attack and stroke are much, much lower. So don't just treat one aspect. Don't just treat the cholesterol if they're hypertensive. Don't just treat the blood pressure if they have, when you can add the cholesterol treatment. So what do we see? Well, with an ACE, you see a 25% drop in the heart attacks and strokes. Add a thiazide, it goes to 50. Add the statin, it goes to 75. Now, statin's more powerful. Why doesn't it look that way? It's because once you already drop the risk, you can only drop that risk half the way, which is what it did, 73%. But now also take a look at aspirin. Now, aspirin used alone is sometimes somewhere between 14 and 19% effective in dropping heart attacks or stroke. But by the time you add aspirin to a 75% lower risk, you're really down to about a 2 to 4% benefit, which means if they don't take the statin, aspirin maybe is pretty important. If they take a statin, it may not really be very important. So, and of course, Scott Flynn can tell you about a statement that just came out, and we'll cover it in another statement, saying that indeed it may not be worthwhile in primary prevention. So what about blood pressure? Because we do want to get blood pressure down, and by the way, in African Americans, calcium channel blockers are better to start with, so you may see a variation in the next presentation, but it could be either way. And the bottom line is about a 10% drop with an ACE to 25 with a thiazide, and then calcium channel blocker 33. So you may use them in different order, but you get down to a pretty darn good blood pressure effect. And why do I mention those three drugs? Because this is what, and how many here know of Joel Handler?
He spoke here
Yeah.
in January.
And Joel was in on devising this when it came out. So the issue is start with something so simple. The lisinopril, hydrochlorothiazide, a half to 1 to 2, add a calcium channel blocker. So what are the results when we did that along with the lipids? And what you can see here is about 9 years after we started treating hypertension fairly vigorously with this exact combination as the thing that we were looking at. And you can see on the top a 30% drop in all MIs, and on the bottom a 60% drop in STEMIs. In the middle, what you can see is the non-STEMIs, but the data were confused because they added in a troponin diagnosis, which adds in more people. So you can see a bump and then back down again. But the other two numbers are solid. ACEs, ARBs went from 20 to about 33%, statins up to about 30, closer to 35% from 10. So you can see we were working well on that. This is where the blood pressure went from 40 to 80% with this. So one of the things you could do in LA, one of the things we did in San Diego, is we said, there's 1,000 ways to go with blood pressure. And one of our elite groups, where the problem they were having is everybody's doing it a different way. We couldn't make a system out of anything. And we couldn't, you know. So we just said, what if everybody agrees that this is one way to go? Would you agree with that? Everybody agreed. And then we could really move. We could make, you could tell everybody on your team what to do. They all knew what the next step is. Everything could be programmed. Everything could be metriced and monitored. And suddenly the thing works. So I'd encourage you to think about any which way you want to do it, but to do it. Now this is really important for the African Americans and this talk coming up. This is the Kaiser data and that we just showed, but they looked at it by age. And what you're going to see is that for strokes and heart attacks, under 45 improved the most. So let's take a 35-year-old African American. Let's screen all of them. And as soon as you see they're hypertensive, can you tell them that if we treat you, we think are going to make a major difference? This is the data. This is it. And you can just see in strokes, it's even bigger. So the bottom line is we need to work our way down on the screening, and especially in the African Americans, but really in everybody, anybody who's high.
Can
Now,
you go back to that slide for a moment?
Sure.
That under 45 group, it really appeals to me, Jim, because what we see in the data writ large across the country is we're doing a great job with those over 65.
Yeah, right.
You see that there.
We were already
But
doing that.
In
This
the
is-
under, the 45 to 65 group, which is our key focus here, we have not been doing well. And I have to say, I am a prime example of this, where I come from a family with a lot of cardiovascular. And Jim and I were having lunch in San Diego in 2011. And he said, Hattie, what's your LDL? And I said, a pretty high number. Didn't know the meaning of it at the time. He said, are you on a statin? And I said, no. And he said, why not? And I said, because my doctor said I'm too young. And he said, that is absolutely not evidence-based. He wrote me a prescription. He said, I insist that you start this today. And I haven't missed a pill since. So thank you, Jim, for saving my life,
testimony.
maybe.
Yay. Okay, well, we better move along. So how about, and by the way, well, okay, let's go right on to this because we're getting a little short on time. If you're diabetic and you're not, and you're hypertensive, just do TALL. If not, still be sure to start the statin. As you can see here, this is that big, 170,000 patient meta-analysis of meta-analyses, and the statins work just as well in diabetics as non-diabetics. So be sure they're on that and go from there. So what about aspirin for primary prevention? Well, right after the ASPIRE and ASCEND trials came out, New England Journal had an editorial, and Paul Richter, who's worked in this area forever, came out with the editorial and said, in primary prevention, the benefit is so small, and the risks are still just as high as they were if you treat somebody at high risk, that the best strategy for use of aspirin in primary prevention of cardiovascular disease may simply to be prescribed a statin. And if you looked at the data we just saw, duh, I think he's right. And it's in the New England Journal, so that helps. And in Kaiser, the adult age 50 to 59 with a greater than 10% 10-year CPD risk, consider if low bleed risk, AHA/CC says, and the hypertension is under control, or else they have hemorrhagic strokes. And so at the bottom line, I'm saying to folks, you can make the aspirin optional. Talk to them, see about all of these things, but don't spend a lot of time. Don't metric it, You don't have to follow it up all the time. You can't have prescriptions anyway, so it makes it easier. But it's supposed to be. Is it possible to lower CVD in the community? So RightCare proposed a San Diego County pilot for prevention. It organized us like it organized, not it, Hattie organized us like Hattie organized you. The competitors had not worked together, and it took a while to build trust. There was some trust that had to develop inside the community. But the uniting thing is this so important that it's worth working together and sharing? And the bottom line is going around everybody in the room, every medical group, yes, 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 yes. And since none of us could do it alone, we started working together, and they felt, actually, the groups that were not doing really well felt that this was so valuable to them for picking up some of the things the groups were doing that were working well, that they kept coming to the meeting. And so the bottom line is to have big impact. They went after heart attack and stroke. Made the grade. We did a grade-like assessment, and we said it was. And it's high and medium risk patients, so we were ticking off all of the population principles. So what happened between 2013 and 17? We went from 70% to a little over 80% on blood pressure control, beating the national and the California averages on cholesterol, which is the only data we have because they changed from measuring cholesterol to taking the statin. We went from under 50% to over 60%. So you can see that the metrics indicated it was pretty good. And this is a slide you probably have all seen, but this is the one that showed that around California between 2010 and 2016, a 7.6% drop, and in San Diego, a 22% drop. If we would have been only 7.6, we would have had 3,800 more events, and the cost would have been $85 million. And if all of California would do this, 41,700 events and 935 million. So impact could be big if you do it. Now, this is your data, and I can tell you when we started out, and Scott, I think, would be able to verify that this looks a lot like what Kaiser, or what San Diego's data look like. And so it's a great place to start. You just start working. So what to do? So we're going to go fairly quick because I'm really running.
You've got till 1.
Okay.
So we can just do all the
Yeah.
Q&A
Okay.
after the
Thanks.
barbershop is.
So what to do, given a small change is more, in the whole population, more effective than a large change in high risk. The quote here was from Rose and Schillinger, replace intensive with low-cost interventions that engage more people. And the most important 3 factors is simplicity, simplicity, simplicity. And that's what ALL was. Simplicity. The other factors are it needs to be cheap, and as you heard, 25 cents a day, and it needs to be easily implemented. Providers needed that automatic reminder, and Kaiser has done that well. Somehow or other, in the community clinics, they would put a flag on the front of the chart, the manual chart that they were using that said start the statin with the prescription. So any way you do it, you need to flag them. And then you need to metric it and see that people are actually doing it. For the patient, you make it worth their while. And if they're either hypertensive or diabetic, I just ask, do you know anybody who had a heart attack or stroke? Any relative or friend under, say, 65? And they all do. And these are inherited things, and people can say, you're at a high risk for that because of your diabetes or hypertension. And you could drop that 75%. Would you like to hear more? And so, things like that. So we're trying to make it really simple for everybody. What about diet and exercise and smoking? Well, smoking cessation has to go, of course. Diet and exercise, of course, try it. But the biggest problem we had with diet and exercise and diabetes was people would say, yeah, I don't want to take any meds. I just want to, go home and I'm going to lose more weight. I'm going to exercise. So the answer to that has to be something like, okay, either I think we should start it today, and if you come back and have lost the weight and are exercising, we'll stop it. Or come back in 6 weeks. Tell me how much you're going to lose, how many minutes a day you're going to exercise, and if that didn't work, would you consider it then? So you don't let them off the hook, because that's a big principle. Okay, so how to do it, accountability, the automated messaging, and tracking a metric. The metrics that track really well are you just tracking whether the prescription was written. Most people can track that. If you can, track whether it's filled. And then for follow-up tracking, refills. And that works reasonably well. Obviously, if you have a systematic way of doing it, great. But if not, drug reconciliation when they come in. Are you still on whatever? So that's really the end of the talk. I'm just going to mention that in LA, Kaiser has been very interested and working hard in the community clinics to improve cardiovascular disease. And as I said, the county, Dr. Gooderman was unbelievably good at this, very, very successful, et cetera. In the other community clinics, the activities happen. Riverside is very strong. They just approved another go at cardiovascular disease over the next few years and funded it, so that if you decide to do something, I would hook you up with the Kaiser Community Benefit also, because we need to get in the community too. So I think this is about the same thing. So I think I'm done with this. Any questions? Yeah.
Your slide about the statins and how important they are, even just in the hypertensive population, is well worth thinking about again. Can you comment on the issue of not even needing a high LDL or cholesterol in the effective statin? And then secondly, we see a lot of, seems to be more than is really happening, myopathy, myalgias with the statins. Did you have a lot of that in, because you were giving a lot of statins? Did you have a lot of that feedback where people thought they were having myalgias and had to change?
I didn't plant those questions in your get up.
Not at all.
Excellent questions.
Jim, would you please use the microphone with the answer?
Oh, okay. Okay.
We just think alike.
Okay. So the first part was
The statin and the LDL.
Oh, yeah. So it really turns out that when you look at the that same meta-analysis, 170,000, if the LDL was under 70 or over the top, they got the same percent drop. Now, of course, it was higher, the risk was started higher, but if they're over 10% risk, that's all you need. So the bottom line is, as you know, even dropping from 50 to 20, 25 gave you some little bit of gain, but the big gains are down to 70 at least. And so you can start anybody, the bottom line is plaques are being laid down from age 15 in American people, and so if you can start them, anybody who's high risk, you can start them, and you're probably going to succeed. And the second part was?
The issue of the myalgias and people wanting to stop stuff.
Oh, yeah, I just had the same thing the other day. One of the groups who doesn't work on this really well says, every time we go to do this, all we hear is these aches all over. What do you do with that? Well, when you really look at the literature and you look at all the randomized control trials, stopping and restarting and so forth, there's about a hardcore 5%. And with everybody else, if you stop them and restart them, they can stay on it. So the bottom line is no. So I just told them, look, if you got a hardcore 5%, don't ask them again, leave them alone. But there are a whole lot of people who run out of the meds or who have an ache in their leg, they stop it because of that or whatever. So you just say, go pursue it, and so for adherence and so forth, we just continue to rework them all. and then you end up with just 5-10%.
So we're just gonna do 2 more questions. Janina Morrison from the county and Earl So from VA, and then we're gonna move on to the Barbershop project.
So I have a question actually for my primary care provider hat. Because my curiosity with lipid control is I have patients who say they're taking it, but their numbers aren't coming down. And I've just decided I don't think they're taking it, but is it possible they're not working? Or in general, if you prescribe the right statin, you should see the numbers come down?
They're very, very effective.
That's
So
what I
it's
thought.
unusual, it would be unusual, but if you do look at the results in the trials that where the drugs were approved, there was a 5% where they didn't get much of a drop.
But
I don't know if they were taking it or not, but, yeah. So I could say that I would go with a Rizuva and try it if you can get it cheap enough.
I mean, the adherence is, in the population I take care of at the county, it's so hard. I think there's a lot of media about statins, like my patients are always telling me, I saw something on the news, it's gonna do this, it's gonna do that. So I have such a challenge with people, I think they just don't take them.
Yeah, and I think you just have to keep working. What do you think's going, what's really worrying you about yourself? And try to work that angle. And talk about the benefits, 75% drop or 50% drop.
And maybe, yeah, I was gonna say,
Oh,
Steve
sorry.
Chen should be able to address
No,
this.
well, I wanted to ask, are you seeing this among both primary and secondary prevention patients, or is it one versus the other?
I would say it's all of them,
Really?
so
Okay.
definitely secondary prevention.
Interesting.
Just, if you just, and we just don't take no for an answer, and you just keep going after it and after it, and you can, and look at the data, you can get above 80%. A lot of people get above 80%. Get above 80%. If there are other barriers, keep working until you get above 80%. After 80%, maybe you're in the, and it was one of the.
Dr. So?
Yeah, hi. In the world of HIV, where I spend some of my time,
Yeah.
combination single inhibitor
Yes.
regimens are the standards, and it seems like those are underutilized in the field of diabetes.
Yes.
Do drug companies have any interest, financial incentive, or any interest in starting a metformin, statin?
Yeah, I actually have testified in front of the FDA for this. The FDA is actually ready to do a combo pill. It turns out that we have a problem in America where every individual physician has his own bundle that he wants, and every bundle costs $1 million to approve. So the bottom line is absolutely nobody has ever gotten anything started. And yet the blister pack is, I think, the ideal next step. And I think Kaiser is getting that thanks to somebody who came from the county, from the head of pharmacy, and we're going to try to do that. So I'm telling the people, look, this is your heart protection pack. It's going to protect you these 3 ways, or 2 ways. Get rid of it. I was going to change it. It's going to protect these 2 ways, and you just take this blister every day. And I would love to do a study inside Kaiser with that. In general, you get a 20% better adherence right away, right? So I think I need to stop. Thank you.
Great, round of applause. So we are blessed with an amazing amount of talent in the room today. Dr. Jim Dudl will be with us for the rest of the day because our concept of having these 2 topics on the same day was to think about how do we combine these ideas of the bundled protocols used by Kaiser and the community clinics successfully, and the protocol approach that the Cedars Sinai cardiologists used along with the USC pharmacy folks to put together a protocol-based approach to tackle a very high-risk population. So with that, I also want to say that Steve Chen has been one of our other early true believers and huge supporter of RightCare to bring it to LA. Without Steve, we would not be here. So thank you, Steve.
Thank you. Oh, that's true. Well, I'm not some of that great talent. I'm just a transition person. So Hattie asked me to just give a little quick history on the Barbershop program, at least when Dr. Victor's first arrival in LA and how we evolved into involving pharmacy. So I'll do that very quickly and then introduce our esteemed speaker. So when Dr. Victor arrived, must have been, 10 years ago maybe at this point, he started speaking to someone named Rita Shane at Cedars Sinai, who's the director of pharmacy. And she quickly connected that his work was in the underserved communities, and